Welcome to the Deep Dive. This is where we take a whole stack of information, could be articles, research, notes, you name it, and really boil it down. We extract the key insights so you can get up to speed on complex stuff fast and feel, properly informed. Today, we're diving into something pretty fascinating, actually. It often flies under the radar. Primary hyperaldosteronism, also known as Conn syndrome. Bit of a mouthful, I know, but trust me, it's got some really significant implications and some surprising facts, too. Our mission: guide you through the essentials of this endocrine disorder. Make it clear, make it engaging, and show you why it actually matters.
Absolutely. And our goal is to give you that shortcut to really understanding it. So primary hyperaldosteronism, at its heart, it's an endocrine thing, a hormone problem. Specifically, the adrenal glands, they just start making way too much of a hormone called aldosterone. And this extra aldosterone, it creates a very specific set of problems. You get persistent high blood pressure, unusually low potassium in your blood, and this shift in the body's acid-base balance, we call it metabolic alkalosis. Understanding it is really key because, honestly, it's a hidden treatable cause behind a lot of high blood pressure cases.
Yeah.
More common than people think.
Okay, let's unpack that definition a bit more. Primary hyperaldosteronism, or PHA, what are we really talking about?
Right.
My notes say it's excessive aldosterone from the adrenals, right?
Yeah.
But the key thing seems to be it's independent of the normal control system, the renin-angiotensin system. So like the adrenals are just going rogue, making too much hormone without the right stop signals. Is that the idea?
That's precisely it. Yeah, rogue is a good way to put it. Think of it like your adrenal glands normally listen for signals, like from that renin-angiotensin system you mentioned, which helps manage blood pressure and fluids. But with PHA, they're basically on autopilot, just churning out aldosterone, whether the body needs it or not. And because it's unchecked, this constant production leads directly to that triad of characteristics we mentioned.
And that triad is the high blood pressure, the low potassium, and the metabolic alkalosis.
Got it. So it's not just about blood pressure then. It's like a domino effect hitting your body's basic fluid and electrolyte balance.
Exactly right. These aren't random symptoms showing up together. They are the direct physiological results of too much aldosterone messing with the system. It's that constant hormone output driving it all.
Okay, so that leads perfectly to the why. Where is all this extra aldosterone coming from? Is it always the same thing causing it, or? That's a really good question. And the sources show, well, there are actually a few different culprits. The most common one, by far, we're talking maybe 50 to 70% of cases, is something called an aldosterone-producing adenoma, an APA. People often hear it called Conn's adenoma. It's basically a small, benign, like a non-cancerous growth on one of the adrenal glands. Think of it like a tiny part of the factory just gone wild, making tons of aldosterone. Then, the next most common, maybe around 30% of cases, is bilateral adrenal hyperplasia, sometimes called idiopathic hyperaldosteronism. In this case, it's not just one spot. Both adrenal glands are generally enlarged and overactive, diffuse, you could say. There's also unilateral adrenal hyperplasia, just one gland enlarged, but that's pretty rare. And then you get into the genetic side, familial hyperaldosteronism. There's type I, that's glucocorticoid remediable aldosteronism, GRA. It's inherited, and the aldosterone production gets triggered by ACTH. ACTH is usually for stress hormones, but here it mistakenly tells the adrenals, make more aldosterone. Then there's type 2, which doesn't respond to glucocorticoids and usually involves an adenoma or hyperplasia, just like the non-familial types. And lastly, super rare, but you can have an adrenal carcinoma, a cancerous tumor that pumps out aldosterone. Very aggressive, though.
Wow, okay. Quite a few potential causes then. Now, this is where I think it gets really interesting. The how. Can you walk us through the actual biological chain reaction? How does too much aldosterone cause these specific problems? Hypertension, low potassium.
Yeah.
What's happening inside?
Yeah, it's a fascinating cascade, really. So you've got excess aldosterone, its main target. The kidneys, it basically shouts at the kidneys, hold on to sodium, and while you're at it, dump potassium. Now, water follows sodium, right? So when the kidneys hold on to more sodium, they hold on to more water too. More water means more volume in your blood vessels. Think of it like turning up the tap on a garden hose.
Pressure goes up.
Exactly. The pressure inside that hose, your blood vessels, increases. That's your hypertension. Direct link. At the same time, the kidneys are being told to waste potassium, get rid of it. So your body flushes out too much potassium, and you end up with hypokalemia, low blood potassium. And that's why people can get muscle weakness, fatigue, cramps. And the really dangerous bit, cardiac arrhythmias. The heart needs potassium to beat correctly. Plus, the kidneys are also pushed to excrete hydrogen ions, lose acid. That leads to the metabolic alkalosis. Your blood becomes too alkaline. And one more crucial piece, because the aldosterone is being made autonomously on its own, it tells the body's normal system, hey, we don't need any signals. So it suppresses renin production. That low plasma renin activity, or PRA, is really typical, and it becomes a key clue for diagnosis.
Right, that makes sense. So if someone's experiencing these kinds of things, the muscle cramps, the high blood pressure that won't budge, how would they or their doctor even suspect THA? What are the key clinical features to look for? Because, I mean, fatigue, high blood pressure, it could be a lot of things.
That's absolutely true, and that's precisely why it can be missed. It often hides in plain sight. From the blood pressure angle, the big red flags are resistant hypertension, that's high blood pressure not controlled, even with 3 or more different meds, one being a diuretic. Or hypertension that's really severe or starts unusually early, say before age 30. If someone's blood pressure is just stubbornly high despite treatment, PHA needs to be on the radar. Then, looking at the low potassium side, the hypokalemia, symptoms can be things like unexplained muscle weakness, feeling tired all the time, frequent cramps. And because low potassium messes with how the kidneys handle water, people might notice they're urinating a lot, polyuria. That often leads to getting up at night to pee, which is nocturia, and feeling really thirsty, polydipsia. And as we said, those cardiac arrhythmias are a serious potential consequence. For the metabolic alkalosis, it's less common to have obvious symptoms, but some people might get tingling or numbness. That's often because alkalosis can affect calcium levels too. And in really rare severe cases, you might see tetany, which is like involuntary muscle spasms.
Okay, so let's say the symptoms are there. The suspicion is raised. How do doctors actually nail the diagnosis? What's the process look like? It sounds like it needs to be pretty specific.
It absolutely does require precision. It's usually a multi-step journey. Step 1 is screening, especially for those high-risk patients, the ones with resistant hypertension, for instance. Now, here's a key point, maybe even surprising. While that classic picture is hypertension plus low potassium, studies show maybe 40% or so of people with PHA actually have normal potassium levels.
Wow, really? So you can't rely on low potassium being there?
Exactly. Its absence definitely doesn't rule PHA out. The main screening tool is actually looking at the hormones themselves: plasma aldosterone concentration, PAC, and plasma renin activity, PRA. Then you calculate the ratio between them, the PK.PRA ratio, often called the aldosterone-renin ratio, or ARR. A high ARR, say over 20 or 30, especially if the aldosterone level itself, the PRC, is also elevated, maybe over 15 NGDL, that strongly suggests PHA. And remember that renin suppression. We expect to see low renin, a PRA typically less than 1 NGML-HR. So if that screening ARR comes back high, the next step is confirmatory testing. You need to prove it's truly autonomous production. There are a few ways to do this, like an oral sodium loading test, a saline infusion test, or a fludrocortisone suppression test. The basic idea behind all of them is to challenge the adrenal glands. You give the body a signal that should normally make it turn down aldosterone production.
Like loading up on salt.
Exactly. With the oral sodium loading test, you eat a high-salt diet for a few days. Normally, your aldosterone would drop, but in PHA, it stays high. The glands just ignore the signal. Same idea with the saline infusion test. Giving IV saline should suppress aldosterone, but in PHA, it fails to suppress. The production keeps going. These tests confirm that the aldosterone production is indeed out of control. Okay, so once PHA is confirmed, the final piece of the puzzle is localization. You need to figure out where the excess aldosterone is coming from. Is it one gland or both? Imaging, like adrenal CT or MRI scans, can help. They might show an adenoma, that little benign tumor, or maybe enlarged glands suggesting hyperplasia. And this is really critical for deciding on treatment. The gold standard test is adrenal venous sampling, or AVS.
Adrenal venous sampling sounds invasive.
It is more invasive, yeah. It involves threading catheters into the veins, draining each adrenal gland to directly measure aldosterone levels coming from each side. But it's the most accurate way to tell if the problem is unilateral, like a single adenoma on one side, or bilateral, affecting both glands. And that difference is absolutely key for treatment.
Right, because the treatment would be totally different depending on whether it's one gland or both.
Okay.
So once it's diagnosed and localized, what are the solutions? What are the treatment options on the table?
Well, the treatment is really tailored to that finding unilateral versus bilateral. If AVS shows the problem is coming from just one side, either an aldosterone-producing adenoma, APA, or maybe that rare unilateral hyperplasia, then the primary treatment is surgery, specifically a laparoscopic adrenalectomy.
So removing the faulty adrenal gland.
Precisely. It's usually done minimally invasively with small incisions. Afterwards, patients need close monitoring, of course, blood pressure, potassium levels. Sometimes the remaining adrenal gland needs a little time to wake up fully, so temporary mineralocorticoid replacement might be needed. But the really good news here is that surgery can actually cure the condition in a high percentage of these unilateral cases, maybe 60–70%. Now, if the problem is bilateral hyperplasia in both glands, or if surgery just isn't a good option for a particular patient, then the approach is medical management. Lifelong medication, usually. The mainstays are drugs called mineralocorticoid receptor antagonists, or MRAs. Spironolactone is often the first choice. It blocks the effect of aldosterone. It works well, but it can sometimes cause side effects, particularly gynecomastia, which is breast enlargement in men, because it's not perfectly selective.
Oh, okay. Are there alternatives?
Yes, there's eplerenone. It's a more selective MRA, so it tends to have fewer of those specific side effects like gynecomastia. It's often used if spironolactone isn't tolerated well. On top of the MRAs, some patients might still need potassium supplements if their levels don't fully normalize. And they might also need other blood pressure medications like calcium channel blockers or ACE inhibitors to get their blood pressure fully under control. Oh, and for that specific genetic type, familial hyperaldosteronism type I, the GRA we mentioned, there's a very specific treatment. Low-dose dexamethasone, a type of steroid, it suppresses the ACTH signal that drives the aldosterone in that particular form.
It really sounds like getting the right diagnosis and figuring out the cause is absolutely crucial for picking the right path forward. But what happens if this condition just isn't caught, if it's left untreated? What are the risks down the line? And conversely, what's the general outlook for patients who do get diagnosed and treated?
Yeah, untreated PHA is definitely not benign. The risks are significant. Obviously, the chronic high blood pressure itself is a major problem. Over time, it dramatically increases the risk for serious cardiovascular events, stroke, heart attack, heart failure, and it causes significant damage to the kidneys too. The severe hypokalemia, the low potassium, also carries risks, as we touched on. Those life-threatening cardiac arrhythmias are a real concern, and in extreme cases, even muscle paralysis can occur. But here's something else that's really important, and maybe another surprising fact. Emerging evidence shows that aldosterone itself, the hormone, seems to have direct toxic effects on the heart and blood vessels.
Wait, independent of the blood pressure?
Independent of the blood pressure effects, yes. So even if the blood pressure is moderately controlled, the high aldosterone level itself might still be causing direct damage to the cardiovascular system, promoting inflammation, fibrosis, things like that. So the risks are real. But the flip side is that the prognosis, the outlook, is generally excellent if it's diagnosed and treated appropriately, especially if caught early. For patients with a single adenoma who undergo surgery, like we said, there's a good chance of a cure normalizing blood pressure, normalizing potassium, potentially coming off all medications. About 60-70% cure rate. For those with bilateral disease who need lifelong medication, the outcomes are also very positive with proper management. The medications are effective at controlling the blood pressure, correcting the potassium, and importantly, blocking those harmful effects of excess aldosterone. This significantly reduces those long-term cardiovascular and kidney risks.
What an absolutely fascinating deep dive. It really drives home how something we often think of as straightforward, like high blood pressure, especially resistant high blood pressure, can have these really complex hidden endocrine causes working behind the scenes.
Yeah.
The mechanisms are just incredible.
It absolutely does. And I think it really highlights the immense value of digging deeper, getting that precise diagnosis, understanding the specific underlying mechanism like in PHA. It just allows for such targeted, effective treatment. It really empowers us to achieve much, much better health outcomes by getting to the actual root cause, not just treating the symptom.
Couldn't agree more. And that actually brings us to our final thought for you, the listener, to perhaps mull over. Considering just how many people struggle with resistant hypertension, and knowing that estimates suggest maybe up to 10%, perhaps even more, of all hypertension cases could actually be primary hyperaldosteronism, how much more attention do you think we should be paying to routinely screening for underlying conditions like this? And what could the broader impact be, not just for individuals, but for public health overall if we got better at identifying and treating these cases much earlier? Something for you to think about.